please proceed with the next section of the agenda.
Thank you very much, Lemmy, for that kind introduction. So members, today we have a very exciting topic on leadership and career growth in nursing and midwifery. And I'll just take you through the agenda for today. We will have opening remarks. We will take you through the webinar objectives. We will introduce our panelists. Then we will get to the presentations, and there will be a session for question and answer. And then we'll have the next step and then vote of thanks. Let me take this opportunity to welcome our guest who is going to give us the opening remarks for today, and that is other than Dr. Ntuli Kabalongwe. Most welcome.
Madam Moderator, he will come in later. Maybe we can proceed with other agenda. Then when he joins, we'll cover the opening later.
Thank you. So our opening objectives, our webinar objectives today, number one is that core leadership competencies for nurses and midwifery, mentorship and professional growth pathways, overcoming barriers to leadership in nursing and midwifery. Our speakers today, I am very excited to introduce to you Dr. Hamin Lita, who is going to take us through the core leadership competencies for nurses and midwives. Dr. Hamin Ida is a PhD holder in nursing science. She is a senior lecturer at the University of Namibia Department of Public Health School of Nursing and Public Health Faculty of Health Sciences and Veterinary Medicine. Her highest qualifications in PhD, but she has other nursing and midwifery education as well. She's the head of Department of Health Policy and Management in the School of Public Health. She has also completed Global Health in an Era of Sustainable Development, course offered by the University of West Sweden and University of Namibia. Prior to the university work environment, she worked at the Ministry of Social Services in Namibia and Oshakati Hospital as a senior registered nurse and served in several projects and committees in Namibia. Collaborative Network for Nurses. Sorry about that. Collaborative Network for Nurses and Midwives through East and Central South Africa College of Nursing, that is ECSACONM. During this period, sorry, you are, Julius, there is a part I'm missing. I'm not able to see because of Julius, because of the our photos. Janet is blocking, and the ECSACONM one. No. Listeners, sorry about that. Maybe I can just read the last one, which I can see. Board and Decentralized Research Ethics Committee in her National University campus. She's a member of the African Forum for Research and Education in Health, as well as a volunteer in community-based care organization in Namibia. Our second presenter is Dr. Mahmoud Alex, who is going to talk to us about mentorship and professional growth pathways. Dr. Mamuna is a physician, global health expert, and founder and principal consultant of Women and Men in Change and Adaptive Global Health Solutions, Global Health Consulting and Leadership Development firms. She excels in strategic planning, program management, and clinical delivery, having worked with having worked with organizations like Smile, Sanford, World Clinics, and the American Academy of Pediatrics. Her passion for quality care in underdeveloped populations has led to improved health indexes and build capacity for over 200,000 health workers in 40 plus countries. Dedicated Rotarian, she volunteers as a board member for the International Rotary Fellowship of the Health Professionals. Daktari also cohorts public health in Renal Life, a platform promoting global health issues and inspiring future professionals. Our third presenter is Dr. Janet, who is going to talk to us about overcoming barriers to leadership in nursing midwifery. Dr. Janet is an impact evaluation expert, executive director for global health mentorships and women of health epidemiology, University of Bern, and she's health systems and policy researcher with experience working in health systems in sub-Saharan Africa, Malawi, Lesotho, Zambia, South Africa, and recently Switzerland. She has published widely, including several frameworks, policy implementation and evaluation of framework, a digital tool evaluation framework, and the impact of evaluation framework. By the Swiss Schools of Public Health, she facilitates the design of research and interventions for impact from the outset. Several senior editorship positions, including senior editor for Women Health Journal, Frontier Digital Health, and she's currently a senior from the Frontier Epidemiology call titled Designing Programs / Interventions for Impact from the Outset. She's a registered nurse with a degree in health science services management and health sciences education, a master's degree in public health, and a PhD in epidemiology. From that introduction, I want to welcome our first speaker. Let us put our hands together to welcome Dr. Hamin Lita to take us through core leadership and competencies for nurses and midwives. Welcome, Dr.
Thank you, Madam Marceline, for introducing me. My name is Hermine Ita, as was mentioned. And just to a point of correction, because some of the introductory notes were not clear, apart from other capacities that were mentioned there, yeah, the head of department I have served, but currently I am not. I have just served for 5 years in our school. Yeah, thank you. We are going to proceed with our session on the core leadership competencies in nursing and midwifery, which are very crucial today. And as we see, we are saying it's crucial because nurses and midwives, we matter. You matter, we matter. Because we make up a big portion of the healthcare providers, and we have to influence policies. We provide services almost every day on the bedside of the patient, as well as for our community out there. So we really matter, and we make impact. We influence our patient outcomes, as well as the healthcare system and community at large. Next one. As the World Health Organization has mentioned, in their documentation regarding the state of the world nursing 2020, the report highlights the indispensable role the nurse and midwives play in the healthcare delivery. And then there is a need to ensure sustainability regarding the services, as well as the competencies they need. Those are the qualities and skills that they should display or possess in order to deliver services effectively. And the resources should really be spent in building the capacity and that competencies of nurses and midwives, because there is a great relationship, according to research, between the leadership competencies of a nurse or a midwife and the outcome of the patient, as well as the achievement of target for health services. The core leadership competencies for nurses and midwives, they are, as they are appearing on the screen. We start importantly with communication. For a nurse or a midwife leader to be able to communicate a message clearly to the others, as well as to collaborate. That is working together within a health team between the colleagues in the same field for nurse and midwives, but also with other interprofessionals, doctors, physiotherapists, as well as occupational therapists and social workers, others that have to do with the care of the patient and the community. Also, ability to manage operation, to delegate effectively so that the work is allocated to the people with the necessary skills and ability, as well as to foster a positive working environment. And all these skills and competencies we cannot do without mentioning empathy as well as cultural competency, because that is the one we are dealing with people of different cultures, whether our fellow nurses and midwives or other members of the health team, as well as our client and families. So cultural competency is also important, and team building, so that we'll be able to foster a good working relationship. And that is what is on the screen is already what we have said, communication and collaboration. In addition to that, critical thinking that is down there is important, to be able to think and solve problems, as well as to listen very well and come up with the necessary action based on the problem at hand. The next one. And importantly, we have also to contribute to healthcare policy development and a commitment to excellence, to display that quality of doing it to the best of our ability, because that is how we satisfy the needs of our one. The empathy and compassion is the one that we didn't highlight there, and development of leadership, as well as clinical skills to be well competent with the subject area we are working in, so that we make sure that the patient is safe in our hands. And team building. Next one. In addition to the competencies that we have mentioned, applicable to the nurses and midwives, or a culture, because we have also male midwives, we call them a culture. There are 10 characteristics that research has pointed out as important to be quite acquainted by and acquired by a midwife. Specifically, like a strong midwife is a good mediator to intervene where there is conflict, is dedicated to the profession, that include now an ongoing effort to better their performance and their knowledge, including evidence-based, research-based practice. Next one. Effective decision-making and being a role model to others, so that the others will learn from our good example as a nurse midwife and to like their profession. So a good role model. Also an advocate to fight for what is right and empower others also to succeed along the way. Is compassionate and is having a vision. Whatever is doing, you have to have that vision to achieve. Resilient, to be able to go on under pressure, although we are not promoting that we have to expose our colleagues and ourselves to pressure, but situation comes that we cannot prevent, and that is the time now the strong midwife will show they are resilient and to be able to continue rendering services and inspire others. Empathy, we have already mentioned. We can move to the next one. The core competencies, they continue according to the recent research that was done by Hennen and others regarding what are the major competencies that are needed. And in that, they find 6 competencies, including the 4 of clinical competency, professionalism, health system strengthening, and health policy leadership domain. And from those, you can see that it is not possible that one only function within those 4. You will find that other more domains are also appearing or related to the clinical area, because you cannot only function in clinical without being professional, or only in profession without influencing health systems. So they are always overlapping. So let us move to the next one. What is on the slide is the list of the core competencies that we have just mentioned to indicate what are the focus areas. And that research that was recently done pointed out those 6: clinical, professional leadership, health system and leadership domain, health policy, clinical and health system and leadership. So as we said, there is always a core combination of skills and competencies required. And clinical and health system also overlap. Thank you. Then we move to the next one to have a look how the elaboration is done on the different domains. The first one is on the clinical leadership, and then they talk about providing leadership to healthcare team and to build a team, assure an expert role and leading others while taking care of monitoring of standards to ensure that the care is of good quality. Always have a look at an analysis of what are the barriers in an organization and engage evidence-based practice. We have to identify relevant scientific health information and be able to build our practice on that. Let us move to the next one. Collaboration, as we have already mentioned, and to align practice to the organizational goal. So we are working with planning in mind. We are working with a plan, strategic plan to solve problems. And we have to ensure that the standard of practice are of good quality. Move on to the next one. The next one is on professionals and leadership. For us to be a good nurse or a midwife or a coacher, there is need to be able to be involved in dynamics of nursing, midwifery, and healthcare organizations. That is how we advance. It's also how we influence practice, and we learn and keep update with the latest development. We give leadership and assume responsibility for growth for ourselves and also for others. And then we have to create a spirit of change and adhere to change. Participate in peer review activities like research, publication, and advanced practice, as well as every advancement that is related to our work and area of practice. Let us move to the next one. The next one is on health and system leadership, that domain, whereby it is expected that a nurse or midwife acquire and strengthen their leadership in contributing to development as well as monitoring of performance, and also group dynamics and group processes so that we facilitate a good working relationship as well as planning for our patients as well as for the community and governmental agencies. We should not only be limited to the bedside. Next one. And the observance of ethics as well as advancement in knowledge is what is emphasized on this slide. And we have to constantly monitor the factors and issues that are influencing our working environment and progress. Next one. When it comes to health policy and leadership, here we concentrate on the competencies or that ability to provide leadership in policy-related activities so that we influence practice for good, as well as articulate the value of nursing to the key stakeholder. We are the one to promote nursing and to share the value of nursing to our stakeholders. Next one. Clinical and health system leadership, core domain. That one is emphasizing on communication and patient safety, as well as also effective plans for practice level, as well as on the system, so that all things are aligned. And also advocate for participating in supporting environmental issues that support client and collaborative practice for the professionals beyond nursing. And the working environment should be cared for, means we advocate for a safe environment for the achievement of health target. And then regarding health system leadership, again, the domain, prepare through mentoring and coaching others so that we ensure that the younger generation nurses, they come, they do the right thing, and they also take the legacy of the good practice ahead. Next one. The policy leadership continue on evaluation and also making sure that the ethical issues are attended to, and the use of technology in communication, including IT skills, as well as other catching up with technology in the healthcare delivery, including the use of new devices to monitor the patient's health status, as well as to manage research. The next one. So those are the key we have to know, and those are the reference. We can read them later as we go. That is the end of the key competencies. I will hand over to the facilitator to give a chance to my next colleague. Thank you very much for listening.
Thank you, Dr. Amin, for your presentation. That was a very, very wonderful presentation. We can applaud her for that, team. And let's go to our second speaker, who is Dr. Maimuna Alex, who is going to speak to us about mentorship and professional growth pathways. Welcome, Dr. Ari.
Thank you so much, Marcelina. And good morning, good afternoon, good evening, everyone, regardless of where you're joining us from. It's my pleasure today to be part of this. And I'll be speaking about mentorship, following on Dr. Lita's presentation. You see where she talked about the domains, and she talked about mentorship and coaching being one of the valuable ways to foster leadership development. So what is mentoring? Simply put, a mentor is somebody who shares their knowledge, skills, and experiences with another person to help them progress. And a lot of times, mentorship can be formal, informal, and we'll talk more about that. But it's simply the process of training, motivating, giving advice, ensuring that there's success of the individual. So there has to be a goal with mentorship. There's a direction that one wants to go. And in this case, we're talking about leadership development. There's coaching that is provided, and there's ongoing support. All of these encompass what true mentorship is. Next slide, please. So why does mentorship matter? Why should we even focus on mentorship? One, like we said, it fosters personal and professional growth, both for the individual, the mentee, and the mentor. And in this case, when we talk about mentorship from an organizational standpoint, it also benefits the organization. It helps guide through leadership pathways. We've heard about all the leadership competencies. The question now is, how do you guide people who want to take that pathway through leadership? It helps to also build the confidence, skills, and the strategic insight. Part of the C's that were talked about previously was, the collaboration, communication, critical thinking. You need to be able to have strategic insight to do that. And we talk about the C's of mentorship as well, which is clarity, communication, and commitment. So you see a lot of overlap. So then what are the models of mentorship? We can have formal mentorship programs, which are often structured and organizationally supported or institutionally supported. You also have informal mentoring models, where there's peer-to-peer mentorship, there's senior to junior support, either on the job or within the community. And then there's group mentorship and communities of practice. For you all who are engaged in this webinar, you're already part of the great community of practice that the ECSACONM team provides. I'll take a moment to share some examples from the field so you would understand that mentorship is something that already exists, and that hopefully it's a resource that you can tap into as you all seek to grow in leadership and your professional development pathways. I'll share 3 examples from Rwanda's National Mentorship Program for Midwives, Kenya's Peer Mentoring Program for Rural Health Workers, and then Uganda's Nurse Leadership Forum. And these all talk about different models. So for Rwanda's National Mentorship Program, it was established by the Rwanda Ministry of Health, and this was in partnership with professional associations and partners like USAID and JPIGO. As we all know, with the changing landscape in global development and financing, there's a lot of conversations as to how to make these sustainable. And what this program basically does is it aims to strengthen both the clinical competencies that we heard of midwives, as well as leadership competencies through structured mentorship programs in both rural and urban facilities. So here they ensure that they were targeting the different contexts. And it focuses on hand-on skills for maternal and newborn health, promoting safe delivery. So that's focusing on the clinical aspect. But then it also talks about quality of care metrics like respectful maternal care, management of obstetric emergencies, and added the leadership and health system competencies as well. So experienced midwives were serving as mentors to junior wives, and they were using standardized, not just clinical checklists, but other checklists as well, using feedback loops and follow-up visits, so ensuring supportive supervision. So some of the outcomes that have been recorded so far is there has been improved quality of care, both in maternal and newborn services within the Rwanda's health framework. And there was also reported reductions in maternal and neonatal complications in the mentored facilities versus those that haven't gone through the mentorship program. There was increased confidence and retention of midwives. So when we talk about why mentorship matters, and that it's not just for the individuals, it's also for the organizations and the system as well. And then Rwanda as a whole has reported improvements in adherence to evidence-based clinical practices, including management of postpartum hemorrhage, neonatal resuscitation. And like we said, it has also reduced retention of midwives, especially in the rural and high burden settings. And we all know that already we have a shortage of the health workforce. So when people are burnt out, people are stressed out, then there is a loss of there's a lack of retention or attrition of healthcare workers. So for Kenya's program, this model focused on rural health workers, and it followed that model we had previously talked about of peer mentoring. So it was an informal, but it was still structured because you have to have that, like we said, the clarity, the commitment, and the communication. So it was structured peer networks that were created. And these were established through NGOs like AMREF and supported by the various county health departments. And what it was focused on was it was designed to reduce the isolation among rural health workers. And for anyone who has worked in a rural health setting before, you know how that is. Either you're the only healthcare provider within a health post or a primary healthcare facility, and the next is either miles away or you don't necessarily have a complete multidisciplinary team. So what this program did focused on was building capacity through the peer-to-peer knowledge sharing and addressing common clinical and leadership challenges. So here they focused on not just the clinical domains, but the leadership domain as well. They leverage technology, and as Dr. Lita previously said, that part of the competencies is ensuring that people have the knowledge and competencies to use informational technology and communication platforms. So in this program, they leverage WhatsApp groups, they did monthly case review meetings, periodic exchange visits, and they were focused on emphasizing practical problem solving, professional development, and psychosocial support. So what were the outcomes that were then reported? There was documented improvements in healthcare worker morale. There was improved and enhanced adherence to the maternal and child health protocols, just due to that continued reinforcement and shared learning that people were now able to leverage from the peer-to-peer support networks as opposed to just working in isolation. This also provided expanded opportunities for rural health workers to access training and scholarships through peer referrals. So if someone knew of a program or had been part of a program within that facility, through the shared learnings, they were able to also share those opportunities with others who, if they were working in isolation, would not have had access to that. And of course, it increased the retention of healthcare workers in those rural postings, so reducing turnover and professional isolation. In the Uganda program, it was a formalized platform. So this also took a different model. I wanted to show you the different models and types of mentorship programs. And this was supported by the Ministry of Health. So there always has to be that organizational support and political will in order to make mentorship effective. So this was also leveraging the Uganda Nurses and Midwives Council and worked with partners like IntraHealth. If you notice in all these examples, there were development partners that supported more from a resource standpoint. And when we talk about the challenges, and my colleague will talk about some of the barriers and how to overcome them, we would also talk about resource constraints. So for this program in Uganda, they paired emerging nurse leaders with seasoned senior advisors in very structured mentorship relationships. So this was very, again, specific, this was purposeful, and this was planned. And it focused on leadership development, health system management, advocacy skills, and policy engagement. So here they focus beyond the clinical skills, like Dr. Lita mentioned, is going into all of those added domains, because all of those are important in order to be able to function as a health system leader. And it incorporates mentorship workshops, leadership seminars, one-on-one coaching sessions. So some of the outcomes that have been reported so far: emerging nurse leaders reported increased confidence in leading teams, advocating for resources, and participating in policy processes. There was also strengthened capacity for quality improvement initiatives at the facility and district levels, which in turn influence health metrics. And then a lot of the nurses expressed enhanced visibility in their health governance structures. So for those who had participated in mentorship, they were able, through this structured program, they were able to be seen at more higher level within like the facility and district levels. And they were able to appoint some of those mentees from the program have advanced to leadership roles in the professional councils as well as in national health programs, which just shows the benefit of mentorship. So we'll be talking about the key challenges, because it's important to understand the challenges and the opportunities and then how to overcome them. There are structural and systemic barriers. These include limited formal mentorship structures within health systems. So we've shared some examples, but you can count how many people have been part of these programs when you rate that in comparison to the number of healthcare workers that exist in those countries. There's inadequate investment in leadership development, and that's just because there's a huge focus on health programming, those vertical programs and horizontal programs, and people don't necessarily think about leadership development, even though we see that leadership is very important for health outcomes as well. Then the agenda biases, we would not, it would be remiss to not mention that there are agenda biases and a lack of representation of women in leadership. Various reports like Women in Global Health report talk about how healthcare workers, females constitute between 75% to 90% of the health workforce. 90% when you account for nurses and midwives, but overall is about 75%. But then on the average, women only attain about 25% of leadership positions. So there's already a skew and a barrier. We talk about the broken wrong syndrome in leadership that accounts for the gaps that we see in representation of women in leadership. Resource constraints, there's high workload, staffing shortages, burnout, reduced time for mentorship. So there really isn't time for people to participate in mentorship programs, except there's protected time. And then there's limited financial and institutional resources in overall to support structured programs. So all of those examples I previously mentioned were supported by development partners. And with the change in the funding landscape, some of those programs have either stalled or they've scaled back significantly, as opposed to trying to expand and scale up. And then we have access and equity gaps. Rural and remote workers usually have few opportunities for mentorship and career advancement, but at least models like the Kenya model that focus strictly on rural health workers shows that it's doable and that it's good return on investment. And then we also have digital divides because there's this increase in innovation in mentorship or training and professional development, leveraging virtual learning platforms and technology. So when there's inadequate access to things like cell phones, to internet, it further increases that digital divide that can limit access to the virtual learning and peer support. So from challenges, we want to talk about the opportunities for advancing mentorship and growth pathways. And this is thinking about it from like a higher level institutional or systemic level. You want to be able to leverage your existing strengths. We've talked about the outcomes that we got from, at least we were able to, that were demonstrated from the previous programs and examples, and the literature shows that mentorship is beneficial. So for anyone here who leads teams or institutions or organizations, it's important to know that you can leverage the existing strengths by building on successful models. Also leverage innovations in mentorship. You can use simple platforms like WhatsApp that people already have access to without necessarily going through high burden, high bandwidth solutions to provide mentorship. It needs to be structured in the sense that it's not structured so it's restrictive, but just structured so you can plan and you can identify goals and you can also measure, because it's important to measure to know whether you're successful in your initiatives or not. So that helps to develop hybrid models in part of innovations in mentorship that expands opportunities for others. One of the ways you can tell people to come in person and take in protected time. And then ensuring that there's policy and institutional alignment. A lot of leadership and workforce development is not embedded into national human resources for health strategies or workforce goals. That focuses more on increasing the numbers, increasing their clinical competencies. But policies and institutions have to also ensure that there's a leadership development goal, because as the research shows, improved leadership drives outcomes significantly. And then strengthening evidence and impact. We've talked about monitoring and evaluation and research is you have to be able to embody. That's why it's important to have it a bit more formalized or structured, is when you have your indicators and your key performance indicators and then you're measuring, you can then embed robust monitoring and evaluation systems to measure outcomes. And these outcomes would include on workforce retention, on leadership progression, like some of our programs shown, and lastly, on patient care quality. You would almost always tie improvement in retention, in job satisfaction, in leadership progression to patient care quality and outcomes, which ultimately is the bottom line. So how do we then build career pathways as we talk about those various leadership, or we refresh our minds on the different leadership domains? Moving from strictly clinical pathways to policy, education, and administration. And how do you do that? You want to set SMART goals, make sure that they are specific, they are measurable, they are achievable, they are realistic, and they are time-bound. And ensure that you have the right resources in order to be able to move. And then engage in continuous learning and cross-functional experiences. As Dr. Lita had previously shared, that you can't just work in isolation as a clinical person. You have to think of yourself as a potential researcher, as a healthcare administrator, as you lead teams, as you manage resources, as you figure out how to efficiently and effectively use both the staff, the personnel, the equipment, and supplies that are available to you. So exposing individuals and for individuals to advocate for opportunities to expose themselves to cross-functional experiences. So from a mentee standpoint, what are some practical tips? Be proactive. Like we previously talked about the 3 C's. Be very clear on what the goals and the expectations are. Communicate, and then be committed to that mentorship engagement. Seek out mentors who align with your goals. Prepare for mentorship meetings with questions and updates. Mentorship is bi-directional, and most of the times is largely driven by the mentees. And then act on any feedback and set very measurable progress indicators as we talk about the SMART goals, whenever you're engaging in any mentee programming or experience. And then when you talk about it from like the institutional level, next slide, please, is creating a culture of mentorship. Organizations should prioritize mentorship programs just because, as research has shown, they are beneficial. Leadership must champion talent development within their institutions. So provide opportunities for identifying talents, for engaging talent, and then for supporting talent. So providing supportive environments. And lastly, linking mentorship to institutional performance and retention. Most of the time, there isn't that tie-in with mentorship, but then when you're able to link it to institutional performance and goals, you see that there is increased commitment, not just from the participants of the programs, but from the institutions, which ensures that you can then get adequate resources and support, both political will from institutions and regulatory bodies, as well as from funding partners. So all of that said, what is the call to action? Whether you are a nurse midwife sitting in a rural facility or in an urban facility, or you are the head of a department or head of institution, regardless of where you are, start or strengthen a mentorship initiative within your setting. Support peers and juniors alongside in their career journeys, because as we talked about, is the ability to share knowledge, skills, and experience with other people to help them progress. And then let mentorship be that bridge to strong leadership in nursing and midwifery, because as we heard, nurses and midwives matter. You are the backbone of the health systems. And I would like to close with this quote. By the late Reverend Martin Luther King. He says, if you can't fly, then run. If you can't run, then walk. If you can't walk, then crawl. But by God, whatever you do, you have to keep moving. So I hope after this, we're going to work and commit to moving the needle to ensure that we can improve mentorship and professional growth pathways, not just for ourselves, but for others. Thank you very much.
Thank you, Dr. Maimuna. That was a great presentation. And participants, as you can see from the 2 presentations that have been done, mentorship is coming out very strongly. And maybe just to share, recently I did a research on performance management, and it also came out that organizations can change because of mentorship and training. So let us embrace this issue of mentorship so that we can develop as a person, and also our institutions can grow because of this mentorship and training. So thank you very much. I want to ask our second presenter, who is Dr. Janet. Dr. Janet, you are welcome. You are coming to talk to us about overcoming barriers in leadership in nursing and midwifery.
Hi, everyone. I'm sorry, I was mute. Are you able to see my screen, everyone? Are you able to see my screen?
Yes, but
Yes.
it's
Yes.
Okay.
slightly
Thank you so
short.
much. Is it okay now?
Yes.
Thank you so much. So really, it's an honor for me to be here to speak to the backbone of the healthcare system, as the previous speaker has just alluded to. So really, I don't know where you are. If you're in a room, I just want that you hug yourself and tell yourself you matter. If you're in a room with others, just hug each other and tell each other that you matter. Okay, so nurses and midwives really matter. So I'm saying this not just to tickle your ears, but really this is something I try to say. I also have written about that, and I take every opportunity to remind people that the healthcare system in sub-Saharan Africa is nurse-led. So I am an advocate. The previous speaker, so Dr. Ita and also Maimunat, they have touched on this. So 90% of the global healthcare workforce is represented by nurses and midwives. And you really impact on both patient and outcomes and also the community and well-being. And you are the heart of the healthcare. And midwives, I don't have to tell you, you know that you do bring life into this world. So you play a very, very critical role. Before I go into the barriers, let's look a little bit at how nursing started, okay? So it emerged from a military context and with these hierarchies and structures, hierarchical structures. So it started really in the Crimean War, and this was Florence Nightingale, led by 38 nurses caring for wounded soldiers. And then in 1860, the first nursing schools were established, and thereafter nursing expanded during World War I and World War II. But there was also this reinforcement of the hierarchical structures. And the present day nursing still carries elements of this military heritage. So I'm saying this to say that, are we kind of stuck in history? Because there's that strict hierarchy and chain of command. So what are the barriers to leadership in nursing and midwifery? So we split this into three categories: personal barriers. At personal level, we have that often the imposter syndrome. Even though nurses can attend the same courses and excel, they still doubt. There's that self-doubt. And also nurses find themselves really playing multiple roles. You are a mother, you are a sister, you are a daughter, you are a daughter-in-law. And how do you balance that work and professional life? And then there are also professional barriers where there is, as we have heard, there are mentorship programs or there are leadership trainings, but they're not sufficient for everyone. How many really get absorbed into these programs and limited mentorship opportunities? The Dr. Maimunat spoke about the gender bias, where we know that 90% of the healthcare workforce in nursing are women. So there's that structural or societal bias towards women. Can women be leaders? Let's take a look at this. The International Council of Nurses, it's really a federation of more than 130 nurses associations, okay? It was founded in 1899, and women make up 90% of this workforce. But despite that, men are disproportionately represented in leadership positions. Let's look at the current leadership at the International Council of Nurses. I didn't know, I actually had to look at that, and we can see 90% of the nurses and midwives are women, but look how many men are in leadership. And if we look at the top leadership, both are men, okay? So what I want to talk about is how we as women, we are actually acting as obstacles to leadership on our own. And the nursing and midwifery, in particular, when women adopt or they get, and if we look at the top positions, leadership, masculine work persona, so they try to behave like men. That culture of dominating each other, that culture of keeping the others down. So I really think one of the things that we need to do as nurses and midwives is to look at this. How are we playing into this? And if we want to overcome that, we also need to have these strategies at personal, professional, and their structural at structural levels. So at personal level, it's really about educating oneself, developing those skills that we need. And in the professional setting, it's about ensuring there's mentorship and leadership and supporting each other, creating that environment. Dr. Ita spoke about the role of leaders is creating a positive work environment, and that's one thing. And then at organizational level, we really need agency to do this. We can't do this individually, but we need definitely to have novel ways of engaging with the decision makers for us to make strides at structural level. So this whole issue of, as women, it's a women-dominated field, but women tend to then act like men. What I want to say today is there is a place for femininity at the workplace. We all want to be in a workplace where it's flexible, where it's adaptable, where it's caring. But we tend to find ourselves in environments where it's competitive, where there's this backstabbing, there is gossip, and you know what I'm talking about. And so a challenge to you is let's be proud to be women, and there is place for femininity at the workplace. So that is what we call kindness leadership. What is kindness leadership? This is intentional leadership with a clear understanding of how leaders conduct themselves and treat their staff. So kindness leadership is really needed now more than ever in nursing and midwifery. We want to do away with those toxic environments which are causing burnout. We want to make sure, as the earlier speaker, Dr. Maimunat said, improve retention and enhance the workplace culture. But I mean, we are here for the patients. We definitely want to improve patient care. So you might not know it, but there is most probably one nurse you were kind to who still thinks of you because you were kind to them. So kindness is a virtue. And you might want to say, because somebody raised this important issue, we have Gen Z. Yes, Gen Z actually is a blessing in disguise. They are asking for flexible work environments. They are seeking meaning and balance. And you might say, yeah, but I can't do that. My hands are tied. It's definitely true, but this is also an opportunity for us to find novel ways of engaging with all key stakeholders, including the Gen Z and the decision makers. So we saw this, that many, it's not only the Gen Z, but many employees are looking for meaning. And we saw the massive resignations in 2022 when people ask themselves, is what I'm doing meaningful? So with there are case studies of kindness leadership where this led to a reduction in nurse turnover. It led to improvement in patient satisfaction. In other settings, it improved the birth outcomes and maternal satisfaction, and it also improved the recruitment and retention of nurses and healthcare workers in hard-to staff areas. So kindness leadership creates a positive cycle of care that extends to providers, to patients, and then back again. So it's really a resource that we can tap into, which is not expensive. We have heard, we've spoken, we do speak about the shortage of resources in the healthcare system, but kindness leadership is one resource that is ubiquitous. Okay, grounded in empathy, compassion, and respect. I think all of us want to work in such work environments, as also highlighted by the previous speakers. What was really important in nursing and midwifery, as we have said, you have women standing in the way of other women, trying to keep other women down. But somebody who adopts kindness leadership encourages junior staff to aspire to leadership roles without fear or intimidation. Okay, so leadership is not necessarily loud. Leadership, is something where you look at the results and they speak for themselves. So when we are people-centered versus really like running for, after profit, the financial success, and in the healthcare system, the patient outcomes as well as the healthcare worker outcomes are inevitable. There is a misconception of kindness is often equated to weakness. Being kind does not mean avoiding accountability. Being kind means leading with integrity, with fairness. It also means emotional intelligence. There is this concept called Ubuntu. I am because you are. This is a concept found in all African languages. And I think it really shows that the focus is not about me alone moving and elbowing and trying to get to the top, but going together, communal, rather than this individual focus. Yes, you might be asking yourself, how do we practice that? It often starts with self-respect, and it ends with respect for others. Okay, so when you are self-aware, and this is a person who takes time and wants to say, okay, what makes me behave this way? What is it that's going on with me? You take time, you introspect. Such a person has also, a self-aware person is able to listen to others, is able to connect with others. And when you are able to connect with others, you are also able to empathize with them. Dr. Ita spoke about that empathy. And when we have empathy and kindness and respect for others and their well-being, that's what we call a positive work environment, as the other speakers have alluded to. What is the call to action? Leaders are both made and born, okay? So we leaders are people who are born with certain traits, which makes them leaders, but they also have to work on that. So you need both. You need to work on a personal level, really pursuing leadership education, pursuing training, and when you get a professional position, a leadership position, implement kindness principles and practice that. So leading by example. But structurally, like what we have seen, people still do not see women as leaders. They would rather take a male. If you have two people applying for the same position of leadership, it often goes to a male because of these structural and gender biases. But as a group, if we support each other and not stand in the way of each other, if nurses support each other and not stand in the way of each other, we can actually change. Because if a small group of thoughtful, committed citizens can change the world, indeed, it's the only thing that ever has. So what matters, we need to be cognizant that our context where we work matters, but we need critical thinking. And this is a point that Dr. Ita put across. And critical thinking helps us to also acquire what we need to acquire, our evidence synthesis skills. Researchers are praising evidence, but we also need to evaluate whatever we are doing for impact. We cannot just implement programs for years without seeing any change in our communities. But also resourcefulness. We know, yes, we have shortage of resources, but Dr. Maimunat said also, innovation. We need to look at mentorship models that we can actually come up with in our own environment. So novelty and innovation is really one thing that I would call you all to pursue. Change begins with me. So if we look at all this, at personal level, you can do much more. And rather than wait and say, wait for structural changes, if each one of us begins to work on ourselves, we can create the agency needed. One thing I would like to say is pinpoint is the need to develop these research skills. Pick up your pen, okay? Because if you do not write, other people will write about you and will write for you. And for the, because of on the African continent for far too long, we actually have been only the researched. We were in this cocoon state. But it's high time we become researchers. It doesn't matter which area we are. In the clinical setting, you can have dual roles. Observe what is happening, write about that, research it. Primary healthcare, community healthcare. You can be in a surgical ward. You can be in a maternity ward. Take up your pen and start writing. We need researchers. And that also helps us to innovate, in context-specific ways, because we do not always have to follow what others do. I mean, we can learn a lot from the West, but we do not always have to follow what they have done, okay? So we need to appraise evidence and find out, does this work in our context? If it does, yes, we adopt it. If it doesn't, then we do not follow that. So what I'm talking about is not rocket science. I'm really talking about just being a critical thinker, questioning whatever we see. So one thing I have written about is Talk to Granny initiative. It's really with the rise of mental health issues here in the West. I just thought, okay, what would happen if each one of us, we do that in the African culture. We talk to our grannies, we talk to elderly people, and this gives us that peace of mind. And also you get that mentorship. So why not do something like that? And I also observed, for example, what is happening in the old people's homes, the loneliness, the depression, and yet in the on the African continent, we are actually now building more and more old people's homes. And is that really what we should do? Should we follow what the West did? And can we not see, the results of this? So I'm just encouraging each and every one of us to question before we adopt any initiatives. Let's look at this context specific. Does it work? What evidence is there? About leadership development, this was a topic I'm cognizant of because I did my research in South Africa. It got independence in 1994, and there have been leadership development courses over the past, so 94 to now. You can see how many years it is 31 years, and we're still talking about lack of leadership. So the question is, what leadership approaches work for our context? What's going on? Can we really have leadership development for 31 years and still talk about a lack of leadership? What's going on? Is there something we can change? So I also would like to say I would have fallen short if I leave you, believing, with that impression, leaders are people who have it all together. I just want to say, no, a self-aware leader is somebody who is really cognizant that alone they cannot do it. And I find solace and the grounding in faith. Faith is something that guides us. It's a compass that guides us through tough times, but it also makes us grounded, and it also makes us accountable. So a leader, faith helps leaders to stay grounded and makes them better leaders by actually reminding ourselves that our true power lies in a higher power and not in ourselves. Otherwise, people can become this arrogance that we tend to see, or impressions that we see on social media. So I just wanted to say that. My final thoughts, what are they? My final thoughts are, let us start a kindness revolution in nursing and midwifery. And this is because kindness leadership improves both patient and healthcare worker outcomes. Thank you.
Wow, 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 wow. That is a great presentation, Dr. Janet. As we prepare for our questions, how many of us have taken up their pens, as Dr. Janet has told us? How many of us? By show of hands, you can put on your cameras. By show of hands, how many have taken their pens? You can put on your cameras. How many have taken their pens? She has shared with us the strategies. So we should be able to take up our pens and move on as leaders. She has emphasized on kindness. I just want to give you one scenario as a nurse leader. And this looked funny, but it has something to do with what Janet has just talked about. As a leader, a nurse came to me. I had observed this nurse was not doing well. All of a sudden, she was unhappy. So I called her to my office and I wanted to find out why the nurse was unhappy. So during the chat, the nurse told me, of course, she started crying, and I thought it was something very major. So I really wanted to assist her so that she can continue performing well. And you know what she told me? She told me, sister, I have missed my boyfriend for 2 weeks. So I asked her, how do you want me to assist you? She told me, if you give me time off to go and see my boyfriend, I'll be okay. You know, it looks like someone can laugh about that. So I gave her some time off. And you know, when this nurse came back, she was a great performer, Somebody will take that as a joke, but such simple things that require our kindness can really push nurses to a very higher level. So I want to take this back to Julius to take us through the questions and answers session.
Please tell me if it's working. I'm gonna just Yes, thank you so much for the great question. Kindness, caring, and culture. And that really speaks to what I said earlier. If we look at kindness and Ubuntu, there are so many attributes that are common there. So when we look at our cultures and we go back, we come from a communal culture. It's about caring for each other. It's caring for the orphan, caring for the widow, caring for those without. So I think our culture fosters and actually encourages us to be kind. What we are seeing is something different, where it's individualistic pursuits, where we are elbowing and trying to outshine the other. And if we were to take a step back and look, is that really coming from our culture? It is not. So individualistic pursuits, this is something we see very often in the West. And so we are adopting something that is not really something that grounded in our African cultures. We are supposed to be there for each other, to support each other. I hope I have answered your question. But with regards to nursing and midwifery, remember what I spoke about. Let's look at how midwifery and nursing started in this military kind of structure. So it's up to us now to say, do we want to remain stuck in history, or can we change the narrative as leaders, and leaders, and nurse and me? I hope I answered your question. You tell me.
Yeah, can you hear me very well? So ECSACON offers a fellowship program on leadership and management, but we also have a short course on the leadership and management. And Julius, I think after this webinar, we'll share the more information with all of you, because we have your emails and contacts, so that you can follow on that and we can link you with that. And we are planning to have that mentorship, the virtual mentorship, is it modality with Janet? So we'll communicate, and I'm sure you'll benefit a lot from that. Thank you so much.
Yes, I'm here. Yes, absolutely. And I think Dr. Janet has elaborated a lot on that concept of kindness and just the leadership competencies and characteristics. A lot of times when you talk about leadership has been historically patriarchal. So people assume leadership traits as the more masculine tendencies. You have to be forceful, you have to be strong, you have to be brash. But then the research is showing that leading with empathy even produces more results than the reverse. And I know it was mentioned earlier that people think those are the characteristics of leadership, but no, you can actually let the research show people. And there is a ton of research out there that shows that servant leadership, transformational leadership, empathetic leadership, that those are more desired traits and characteristics that then improve health outcomes, organizational performances. As Marceline shared, she probably has not thought too much about it, but as we've been charged that we are researchers, we should take up our pen. Marceline should probably show what the employee's morale was before she went to see her boyfriend to after. I'm not saying you should give everybody excuse if they tell you, because people will come up with all kinds of excuses. But that is where the emotional intelligence comes into place. That's myth, that kindness is weakness. The research shows that that's not the case, and that tying leadership to some of the more strong masculine traits isn't necessarily right.
Yeah, thank you for the question. And that one starts with the modeling and also making sure that our curricula are prepared in such a way that the new nurses are gradually introduced to the balance of that leadership and ethics should apply, so that we don't really fall into the myth of believing that to be kind is to be sort of not good, but to make sure that they go through it with guidance, case studies, and applying it, and also mentorship from early age, as well as also having them to reflect and guide them accordingly. It's not a one-time thing, but it needs continuous engagement, as it has been said, and it should be applied in both phases: clinical, in a community, in all other areas of nursing and midwifery. Thank you.
Yes. So I thank you so much for asking the question. And you're right. I think what we are faced with as let's say the African continent, is a question of resources. Should not be a barrier. What we need is to be innovative and also critical thinking. So it depends on what you say, what exactly you want to research on. But gathering information, gathering evidence on, and trying to demonstrate whether a certain intervention is working or not does not really take a lot of resources. So I'm not sure what kind of research you have in mind, but if it's a person who is in a clinical area, a person who is working in a maternity ward, who really wants to demonstrate or gather evidence on what is working and what is not. What you need in this context would be a mentor, somebody who can guide you, but then with really very few resources, you can produce that evidence that's needed and write the findings. I hope I have answered your question.
Yeah, so as ECSACON, we are offering a leadership and management fellowship program, but the entry criteria, you should have your bachelor's degree, then you are trained to excel to a specialty level on leadership and management, but we'll communicate back to you with a short course on leadership and management. And the good thing, I have one of the main partner in this short course, Dr. Maimunat Alex. We are working with her on this short course, so we'll give you the full details on that. You give us some time, but we'll offer you the full details and you can log into the course later. But we are working all these. Maimunat and Janet are our good partners in this, in mentorship and leadership and management. and we'll communicate with you. But the fellowship program is on. And as I told you, Julius will share all the details. And you can even find the details from our website, www.ECSACONM.org. Thank you so much. Back to you, Julius.
Thank you so much, Julius, for this opportunity to speak. I want to just say how much grateful I am to have been part of this webinar today. I want to thank God for the opportunity just to be here and listen to great women speak about leadership. I've been a leader in nursing for over 30 years. And I'm so glad that I'm here. So we want to thank God for today, that we have been able to have the monthly webinars. We've never missed any. Allow me also to thank our moderator, Marcelina from Kenya. We have to look for each other and just support one another. Thirdly, I want to thank all the presenters. This has been amazing. You are so practical. You are so challenging, and we are going to learn so much from you. You are shots that Julius will graciously share. Then we see what is it that we can do at our level. What can we do? Let's not just hear this and keep it somewhere. I also want to thank all the 91 participants for just being there today. I'm sure there could have been many more if they knew it was going to be this wonderful. So we want to thank the participants. Please spread the gospel so that next time we have many more. I'm the registrar for the college. My name is Elizabeth, and we have the leadership program pitched at master's level. And at the end of the training, we are hoping that we'll have those leaders who are culture sensitive, who are caring, and practicing the kindness that we have learned today. So I want to thank all of you and welcome you for the next webinar in a month's time. Thank you so much, and God bless.
Thank you. Bye.
Recording stopped.
Bye. Thank you all.
Thank you. Bye.
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 Thank you so much.
Bye.
Thank you. Bye.
Bye-bye.
Thank you. Bye.
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 Thank you, Marceline. This was Dr. Hermina. This was great. Thank you.
Thank you.
Oh, we also appreciate the opportunity.
Lenny, can you arrange so that the slide can be shared?
Jerusalema ikhaya lami ilondoloze uhambe nami zungangishilana Jerusalema ikhaya lami ilondoloze uhambe nami zungangishilana dawo yami ayikholana buso wami awukholana